To the next topic, that's on macular holes. I have two small presentations. I'll be talking to you first on how to improve or what decides the outcome of macular hole surgery, and subsequently I'll be talking about early macular holes. So it's nearly about 25 years now since surgery for macular holes came into practice, and there has been significant development. When you look at the results of the original study by Kelly and Wendell, only half the patients who were operated reported anatomical closure. But today we have a surgical success rate of about 85 to 90%. There are two or three important landmark developments in the last 15 to 20 years. One is the development of internal limiting membrane peeling. And the most important, I think, is the development of optical coherence tomography, which has made us understand about macular holes much better. Third is the development of transconjunctival microincisional vitreous surgery, that is the 23 and 25 gauge instrumentation, which has resulted in atraumatic surgery, and that has again vastly improved anatomical and visual outcomes. Now, if you look at the factors that are predictive for outcomes in macular hole surgery, basically there are two or three important factors. One is the case selection, second is the technique of surgery, and third is the postoperative care, although there are some controversies in each of these areas. Now, if you look at the preoperative assessment, we all know now that the size of the hole and the duration of the disease are very critical. And these are two important factors. Unfortunately, in macular holes, very often when patients come to us and give us a history, the history is not reliable because most often it's an accidental observation. And if you look at the available reports now, especially the large studies, we know now when you have a very small macular hole, that is, as Mahesh said, smaller than 400 microns, we know that nearly we have got 100% anatomical outcome. But the anatomical outcomes definitely decrease as the hole size increases, and when you operate on larger macular holes, it is less, provided you do some of these newer techniques like the ILM flap technique. There are two important issues as far as outcomes in macular hole surgery. One is the anatomical outcome, but as far as the patients are concerned, the patients are more bothered about the functional outcome. And the functional outcome is related to the development of the outer layers of the retina. That's the ISOS and the external limiting membrane. And we now know that there is a progressive, once you have a good closure, a type 1 closure, there is a progressive development, and especially when you have the external limiting membrane that's formed, automatically the ISO is also continuously formed. You can see here a follow-up of our patient over a period of 2 to 3 months. You can see here finally the external limiting membrane, and also the ISO has completely formed over a period of 2 to 3 months, and this results in substantial improvement of visual acuity. So we have done a study, we have done multiple studies on macular holes, and one important study was a prospective study that we did in about 71 patients to understand what are the factors, probably by looking at the SDOCT morphology, whether we'll be in a position to understand basically the outcomes of macular hole surgery. And we measure all the possible indices that are now available in literature to find out which one of them, or is there any relevance to measuring the size of the macular hole and all these factors in SDOCT to decide on outcomes. And therefore, here you can see here, this is how we measured using the calipers, the mean linear diameter, the base diameter, the vertical diameter, etc., and all the indices. And we found that the anatomical outcomes were about 86% as in other studies. And we found that the mean linear diameter, that is the mean linear diameter and the base diameter were statistically relevant when it came to anatomical closure of macular holes. And we also studied the relationship between the ELM and the ISOS and the outer layers with the visual acuity and the macular hole closure rate. And we found that the macular hole index probably had a statistical relationship between restoration of the external limiting membrane, which is vital for good visual improvement. So this is again a take-home message from this particular study. Moving on to the surgical steps, basically each one of us have got our own technique of surgery as far as macular holes is concerned. Basically, I do what is known as initial debulking using the 25 gauge. I do the macular hole surgery now only using the 25 gauge. So I do an initial debulking of the vitreous and subsequently I use diluted triamcinolone. I do not use the triamcinolone per se, but I use the diluted triamcinolone so that to induce the PB, so that this disperses on the posterior hyaloid and you're able to identify the posterior hyaloid extremely well, and this makes the procedure much more easier. And I personally feel triamcinolone helps in doing a near total complete vitrectomy, although there are now reports that you don't need to do a total peripheral vitrectomy in case of macular holes, but definitely triamcinolone helps us in identifying the posterior hyaloid extremely well. Another important advantage of the triamcinolone is to identify what I call is the premacular vitreous cortex. This is very, very important. We need to remove the premacular vitreous cortex, and with the MIVS we are able to go very close to retina and completely remove the premacular vitreous cortex, which is identified by the triamcinolone. Subsequently, I do an FAE. I do the dye injection under air, because this I use the extrusion so that it takes very little time to do an FAE. And the advantage of doing the FAE is that small bubbles of air that collects on the surface of the retina are areas of small vitreous gel, and this allows you to identify the vitreous gel and remove the small areas of vitreous gel completely. And once I do the FAE, subsequently I just inject about 2 or 3 drops of the dye, 2 or 3 drops of the dye on the surface of the retina, and keep it there for a little time, and this gives us good staining. The advantage of this particular technique is that you use very little of the dye into the eye, and also the contact time of the dye is reduced significantly. We are all now experts in internal limiting membrane peeling. It requires high magnification, good clear media. This is very important, especially when we do combined surgery with phaco and vitrectomy, and sometimes by the time we do the phacoemulsification, the corneal edema may create some sort of a hindrance to a good visualization of the internal limiting membrane. And then I use the contact lens and good instrumentation. Now, where exactly to start the ILM peel? Now, the best way, we must understand the ILM is more friable closer to the fovea. So, I usually start the ILM peel somewhere between about 1 disc diameter from this thing, and I do the pinch and peel technique, where I hold on to the internal limiting membrane, shake it up a little bit, lift it, and start the ILM peel. There are various techniques again, but the pinch and peel technique I feel is the safest technique as far as the ILM removal is concerned. So, and I only remove about 2 disc diameters. I do not go up to the arcade. This is the amount of ILM I remove in most cases, because for me, removal of the ILM at the edge of the macular hole, I feel, is more important than the quantity of ILM that we remove, because what we are removing is tangential traction, and the tangential traction has to be removed at the edge of the macular hole. So this is also another important thing that so this is a case where you can see here the visualization is a little difficult, and I am doing the ILM peeling far away from the fovea. I do not know, this is the wrong technique actually, where we have the perivascular perifoveal vessels. So once you try to do the ILM peel very far away, you have the perifoveal vessels, which may result in some sort of an oozing, and you need to be careful on that. But nonetheless, basically once you have, the advantage of going a little far, of course, is that with the rexis may be sufficient enough for an adequate peel with one round of removal of the ILM across 360 degrees. In eyes where the initial peel is insufficient, you can do a second row of peeling, hold on to the edge, and then do an additional layer of peel to increase the size of the ILM peel. But then when you do a second row of peel, you need to be careful again, because you need to hold the forceps vertical. If you hold the forceps tangential, there is a possibility of bleed, and once there is a bleed, then it's difficult. So here's a case where the ILM was removed, but you can see there is an edge of ILM attached to the fovea. So this edge removal is very important. Identify that particular edge and then go around and remove it completely. This is very important. Unless you do this, the macular hole may not close. So as I told you, ILM bleed is again a possible, because of accidental touch of the retina. So when you do the peeling, you have to be very careful and avoid accidental touch of the retina, because once you have an accidental touch, you can get an ooze. And it's not easy to stop this particular ooze, because these are all capillary oozing that occurs from the surface of the retina. So there are other techniques, as I told you, like scraping, which I used to do earlier, but I don't like this technique because I feel this damages the surface of the retina. Although at times you can do the scraping, helps in immediate release of the internal limiting membrane. Very often you need to continuously scrape like what you can see here, and cause a lot of damage to the surface of the retina, and this has got both anatomical and visual problems. Achieving good gas fill is very important, because the principle of closure of macular hole surgery is the macula should be dry in the first 24 to 48 hours. Therefore, achieving good gas fill is very important. And this has been very well documented by Eckhart, where he has done the OCT 1 day after surgery. And therefore, I do an FAE first, and then subsequently, I also do a re-FAE. I wait for about 3-4 minutes, I go in again and remove all the additional, lot of fluid would have collected in 3 to 4 minutes. I do a re-FAE, and also I remove a little bit of fluid from under the macular hole, because the macula, there is a lot of fluid that comes on, especially in large macular holes. I don't do this technique in smaller macular holes because you may damage the edge of the macular hole. But in cases of larger macular holes, I also go just close to the fovea, close to the macular hole there, and you can see a lot of fluid coming in, and the macular hole just contracts. And this also is important. Is face down position necessary? Now this again is a very important point of discussion, because basically the gas bubble has to isolate the macula. Therefore, during the first 24 to 48 hours, face down positioning I feel is very important, because the gas holds on to the fovea and the fovea is dry, and that is how the macular hole closes. So in the first 24 to 48 hours, face down positioning definitely is important. You can also do what is known as a titrated face down positioning nowadays based on OCT. And nowadays in our patients, especially pseudophakic eyes, we do an OCT the day 1 after surgery. And you can see here, day 1 after surgery, you can see the macular hole has closed. So based on this, you can titrate the face down positioning, because you don't need to ask the patient to lie down 4 or 5 days when you know on day 1 itself the macular hole has closed. So you can do in pseudophakic eyes, you can do the OCT on day 1 after surgery, because all our patients are receiving SF6 gas injection. Especially, therefore, you're able to visualize the retina with the machine, and you can do an HD OCT day 1 after surgery. Therefore, what is new now? Therefore, basically, careful case selection, atraumatic internal limiting membrane peeling, removal of the ILM from the edge of the macular hole, and achieving a dry macula in the first 24 to 48 hours, for which I recommend face down positioning. And the most important message I think we need to tell our patients, even if you are not face down, don't lie supine in the first 2 to 3 days, because once you lie supine, the gas is coming up and fluid goes under the gas, and the chances of reopening of the macular hole is very high. Thank you for your kind attention.